So the question is, how do we sequence these drugs when the resistance develops? And we have the luxury to have access to 3 compounds in the second line. And I would basically talk about ALK because, for ROS1 we've had approval for crizotinib, not for these other drugs so much yet. So I would biopsy the patient, see what type of resistance has emerged, but it's heartening to know that brigatinib covers multiple mutations, multiple resistance mutations. So it's a very attractive drug to use in patients who have progressed on crizotinib. In fact, the ALTA trial, the randomized ALTA study, which was randomized phase 2 study of brigatinib in crizotinib failures, which is what led to its approval, shows very impressive activity, actually a progression-free survival in the higher dose arm up to 15 months, which is unprecedented. So I think that it's going to be a very promising drug. It's going to be a matter of trial and error in some patients because ALK patients are not like EGFR patients where half the resistance is due to T790M. Here you have a smattering of different mechanisms. There's no single predominant mechanism. There could be ALK amplification, there could be resistance mutation, other pathway activation. So in that regard, I think it's comforting to know that it covers multiple resistance mutations. So the question is, how do you choose between the 3 agents, crizotinib, alectinib, and brigatinib, with a pattern of relapse, including CNS metastases? So I think in case of CNS metastases, you obviously would want drugs that have excellent penetrance into CNS. And in my view, alectinib and brigatinib have better penetrance. Among those 2, you could go either way. Alectinib is multiple pills, 4 pills to be exact, twice a day. Brigatinib is once a day. So that could dictate whether you go for one or the other. It is also something that you may base on your rebiopsy and resistance pattern mutation. So I think those factors go into decision making for a physician and what drug you have access to, what you can get more easily for the patient, etc. A lot of considerations go into that, and you individualize your decision. So the question is, how do we select among the 3 agents in the second line setting based on their toxicity profile, dosing schedule, etc. And I already alluded to excessive GI toxicity at full doses of ceritinib. That's why lower doses with food are now being studied before the FDA label can be amended. I think it's a huge advantage to have this drug once a day versus twice a day in case of ceritinib and brigatinib, whereas alectinib is twice a day. A lot of my patients who previously took crizotinib in first-line setting twice a day said it becomes a production. I take my nausea pill, then I take the drug, then I eat something, and the whole exercise takes 2-3 hours, and I have to do this exercise twice a day. It takes half of my day to be compliant with this medication. So in that regard, having drugs that are better tolerated, less GI side effects are taken once a day are preferable over other options. So I think that's what really is important to the patient and the prescribing physician.
So it's a very difficult decision which second-line agent to use. Alectinib has really displaced ceritinib, at least up until the spring or summer of 2017 when it comes to a standard second-line agent. Brigatinib, in my opinion, looks as good, if not superior to alectinib, at least in the second-line setting, in individuals whose disease has progressed on crizotinib. If we look just at PFS, the data are just as good, maybe a little bit better for 90 milligrams, stepped up to 180. The CNS penetrance seems to be equivalent. The degree, the toxicities are generally equivalent. Again, I tend to see a bit more myalgias and fatigue with alectinib, and of course we're a bit more concerned about pulmonary toxicity with brigatinib. I've not seen the degree of myalgias and fatigue with brigatinib that I've observed with alectinib. So it's a very tough decision. Brigatinib and alectinib, really depends on very nuanced factors within each individual patient in terms of which agent to use. One additional advantage, at least for brigatinib, is the schedule. Unlike alectinib, it's once daily. Alectinib, of course, is twice daily. And both of these agents have a major advantage over ceritinib, which features a lot more in the way of GI toxicity.
So ceritinib does have activity in ROS1 patients, but brigatinib and alectinib, as best as I know, do not have activity in ROS-positive patients. I know alectinib does not have ROS1 activity. I'm not certain about brigatinib. Ceritinib is not a very effective ROS1 inhibitor, and the likelihood is that it won't be a major drug utilized for the management of ROS1 patients. As far as selecting between these three drugs, I think we can approach this in two different settings. One is, of course, in patients who have previously received crizotinib and have developed disease progression. And then the other clinical setting is choosing one of these drugs as frontline therapy. If we look at the clinical setting where patients have received crizotinib and then subsequently developed disease progression, as far as efficacy is concerned, the overall response rates with each of these drugs appears very similar. The only standout feature as far as efficacy is concerned, the median progression-free survival of brigatinib was the longest at 15.6 months, whereas the median progression-free survival with alectinib is in the range of 8 months, and with ceritinib is in the range of 6 to 7 months. Now, these are across-trial comparisons and have to be viewed with a level of caution, but that's the only measure of efficacy that does stand out among the three drugs. And if we just went based on efficacy, one may consider brigatinib as the preferred agent, but we do not have head-to-head comparison. The mutation profile targeted by each of these drugs does appear to be different in preclinical studies, but the relevance of that in managing patients who have been treated with crizotinib and then subsequently developed disease progression is unclear. It is possible that that in the future, for certain specific mutations, a specific drug may be chosen in patients who have progressed after crizotinib, but we don't have that data. As far as frontline treatment is concerned, each of these drugs appear to be extremely potent ALK inhibitors, and each of these drugs appear to have activity in the CNS. At the present time, I don't think one can determine which particular drug to use as frontline therapy. We also have to consider another drug called lorlatinib, which is not yet approved, but we do have clinical data on the drug. And it does appear to have the broadest mutation activity as compared to the other three drugs. And so it is unclear when that drug becomes available, what role each of these drugs will have. So this is an evolving field. What I can summarize by saying is, at the present time, we don't determine which drug to use based on mutation profile, but do so much more on tolerability and efficacy. Each of these drugs do have activity in the brain. From a tolerability point of view, alectinib and brigatinib appear to be well tolerated. Ceritinib at the approved dose does have significant GI toxicities, and that can limit the dose that can be delivered to patients. And that potential, and since the dose may not be the full dose approved, its activity in the brain does appear to be somewhat lower than what has been observed with alectinib and brigatinib. So if treatment of CNS metastases was an issue in a particular patient, I would prefer alectinib and brigatinib, and I feel at the present time, both those drugs appear to be equally efficacious in the brain. I don't know if I can say one is better than the other. And then it comes down to one's personal experience. For example, I personally have used alectinib a lot more than what I have used brigatinib, and that may make me lean more towards alectinib, though I am impressed with the efficacy data of brigatinib as well. The other thing is the rapidity of CNS progression in itself may not make me decide which drug to use between alectinib and brigatinib, because both those drugs work very well in the CNS. What I will mention is that there is a tendency on the part of practitioners that in patients who have rapidly progressing brain mets to seek consultation with radiation oncology and treat those patients with radiation. What I think should be well recognized is that these drugs do work well in the brain, and this systemic agent could definitely be one of these systemic agents could definitely be a consideration for patients who have progression in the brain, even if it is a rapid progression.